Hello everyone, this is the EMT 200 overview of facial and neck trauma. We're going to cover trauma involving the eyes, ears, nose, mouth, and teeth, throat, and neck. The face and the neck are prone to injury. There's a lot of blood vessels. They bleed heavily. They're also vulnerable. The neck is unprotected from bony structures, unlike other parts of the body. And when a soft tissue injury occurs, we're going to treat that the same way we would elsewhere. So we want to pay particular attention to the airway. Patients who are bleeding into their mouth may need to have their airway suctioned. If they have avulsed teeth, the teeth may need to be removed manually or with a sort of scooped out. And we're also going to want to control life-threatening bleeding, whichever we think is going to harm the patient first. And we're also going to assume that anyone with a facial or neck injury has a spinal injury. And so in that case, we want to use the jaw thrust and turn the patient to the side or turn the back part on the side to let the blood help maintain a patent airway. So one thing we want to do is, for bleeding to the head, we want to use dressing, the 4x4 most likely, hold it in place with roller gauze. And we don't want to apply excessive pressure if there's a skull fracture present. That would worsen a head injury. If there's any exposed brain, eye, or other structures, we want to moisten a dressing, put that on, and cover with a dry dressing. Ice may help. For injuries around the mouth, we want to look for bleeding inside the mouth. Broken teeth and tongue lacerations can become upper airway obstructions. Patients who end up swallowing blood are also prone to vomiting. So if there's an avulsed skin, we actually want to put that back in place. And so we would want to wrap it in a sterile dressing. If it's completely avulsed, so it's separated from the patient, we would want to put that in a plastic bag inside a sterile dressing and keep it cool, but we don't want to place the part directly on ice. It may be able to be grafted back. If it's partially avulsed, then we would want to put it back in place and then dress that with a roller gauze. And in that case, we would want the gauze to be dry. So for eye injuries, these can cause life-threatening, lifelong complications. Normal uninjured eye, the entire circle of the iris is visible. Pupils are round. They're usually equal side, although some patients with a condition called anasarcia may have unequal pupils, and they should react to light. They should also move in the same direction to your fingers. When you do your neuro exam, they should both move in unison. After an injury, the pupil reaction or shape may be disturbed. The abnormal pupil reactions are a sign of brain injury rather than an eye injury, and so we want to assess for that. Foreign objects in the eye may cause irritation to the eye, and if there's a foreign object that's small, we can usually flush that away with a sterile saline solution. So we carry sterile water or sterile saline. A bulb syringe, that'll be if carried in the OB kit, or a nasal airway or a nasal cannula can be used to direct fluid to the eye. If you have working with a paramedic, you have a saline bag, you can connect it to IV tubing, which can connect to a nasal cannula, and that can be used to flush the eye. Or if you have a nasal airway, you can dump water or a sterile water down the nasal airway. So the conjunctiva, the white of the eye, may become inflamed and red. This is called conjunctivitis because it gets irritated, and it produces tears to try to flush the object out. Irritation of the cornea can cause an intense pain as well while you're doing this. There's another device called the Morgan's lens, which rests on top of the eye and can flush things away. So when we flush the eye, we want to flush from the nose side towards the outside, so that'll limit the chance of material getting into the other eye. Foreign bodies will leave a small abrasion on the conjunctiva, so and irrigation may not wash out foreign bodies if it's stuck to the cornea or if it's lying under the eyelid. That's something that the hospital is going to have to get out. If you see a foreign object on the surface of the eyelid, you may try to remove it with a cotton-tipped applicator or a Q-tip, but you want to make sure that it's sterile. And if an object is stuck to the cornea, though, we would not want to remove that. So foreign bodies may be impaled in the eye. In that case, you want to, just like with any foreign body, you want to bandage that in place, cover the eye with a moist, sterile dressing, surround the object with a donut-shaped collar, so like a coffee cup or something along those lines. And you want to dress both eyes to prevent further injury. So that'll limit the patient moving their eyes. When they move from side to side, that's going to make it worse. And when you bandage the eyes, they should be hold the dressings in place. We don't want to increase too much pressure on the eye. That can also worsen the injury. And you also want to consider transport to a specialty hospital. There's a hospital in Philadelphia called Will's Eye, and this may be a patient that's appropriate to take there if there's isolated trauma involved. So if there's burns to the eye, we want to stop the burn. We can flush the same way we would for a foreign body in the eye. Chemical burns, there's an acid or an alkaline solution, and we want to get as much fluid as we can onto the eye. You may actually have to force the patient's eyelids open, and when we flush, we want to flush from inner to outer corner. We want to do this for at least 20 minutes. After we're done flushing, we want to cover it and transport. So during thermal burns, the eyes will close and the eyelids will burn. So we don't want to examine the eyes too much. We don't want to disturb what's happening. We just want to cover both eyes with a sterile dressing, with a moist sterile dressing, and put eye shields over the eyes. Light burns, infrared rays, light, eclipse light, laser light can cause damage. Retinal injuries caused by exposure to light are generally not painful, but they can cause permanent damage. And this would be also, we would cover the eye, place sterile moist pads and cover the eye. Lacerations require a specialist to repair. With bleeding, we would want to control with gentle manual pressure. We don't want to exert too much pressure. If part of the eyeball is exposed, we'd want to apply a moist sterile dressing to prevent it from drying and just keep the eye in place as close as we can. We do not want to reposition the eyeball back in the socket. So blunt trauma can cause I call it the black eye, or a bruise around the eye. Hyphema, that's blood in the eye. Through the iris, you can actually see redness. Orbital fracture of the bones that form the eye can support the blow, and then there's retinal detachment, or is also called boxer's injury, from blows to the side of the head. Patients with retinal detachment may not experience pain in their eye, but they may see flashing lights or specks or floaters. So that's a sign of a serious eye injury. So eye injuries following the head injury, we'll see the eyes don't move together. One pupil is larger than the other. They won't be able to follow your fingers. They're going to be bleeding under the conjunctiva or hyphema. And one eye may even be bulging. The eyes are also prone to blast injuries. So there may be loss of vision. There may be foreign bodies in the eye. And if there's contact lenses, we actually don't want to remove. The only indication to remove a contact lens is a chemical burn. And even then, you want to start flushing. So it can be, imagine a patient's going to be in a considerable amount of pain, and they may be difficult to get the contact lens out, especially if it's not something that you have a lot of experience doing. So it's more important to start flushing before taking the contact lens off. Okay, so nosebleeds or epistaxis are a common cause. The most common is digital trauma. Anterior nosebleeds come from the septum and bleed slowly, and posterior nosebleeds are more severe, and they cause blood to drain in the throat. And that's a concern because it can cause an airway compromise. So one thing we do not want to do if any patient has injury to their nose would be to place a nasopharyngeal airway. The nose is often injured. It's the brunt of takes physical assaults and car crashes. And these can also come with injuries to the face, head, spine. So most patients with a nose injury, you'd want to consider C-spine precautions on. Cerebral spinal fluid, if there's a basilar skull fracture, a fracture of the base of the skull, cerebral spinal fluid may leak out. And again, we would also want to treat those patients for a spinal injury. For the ear, there are three parts. There's external, middle, and inner ear. And when they're often injured, but they don't bleed very much. If the ear is a valve, we want to wrap it in a moist sterile dressing and put it in a plastic bag and keep cool but not too cold. And the tympanic membrane, or the inner ear, these are sudden changes in pressure caused by a blast wave can cause the tympanic membrane to rupture. And this usually will hear spontaneously without any intervention, but it causes severe pain and can cause ringing in the ears. You can also get a tympanic membrane rupture by insertion of objects too far into the ear. such as a Q-tip, or children may place foreign bodies. If there's clear fluid coming from the ear, that may indicate a skull fracture. So facial fractures are usually the result of blunt force trauma. It's cause bleeding in the mouth, inability to talk or swallow, loose teeth, or bone fragments. And they aren't acute emergencies unless there's serious bleeding, although they are very painful and may require a plastic surgeon to repair. Dental injuries, these are traumatic. There's always bleeding whenever there's a tooth that's removed from the socket, which could present an airway compromise, and then broken teeth or avulsed teeth can also cause airways compromise. So when we want to, when we get an avulsed tooth, we want to handle it by the crown rather than the root, the harder part. There's a tooth storage solution. Cold milk is also good for storing tooth, and then a sterile solution. We would want to notify the hospital, and the hospital may have a dentist available to help replace it. So injuries to the cheek, when there's a foreign body into the cheek. And this is something we want to leave in if we can, as long as we can control the bleeding around it. We may want to apply direct pressure on the inside and the outside of the cheek. And when we bandage it, we want to make sure we don't occlude the mouth. So injuries to the neck. So the neck contains many structures that are vulnerable. The upper airway, the esophagus, carotid arteries, jugular veins, thyroid cartilage, cricoid cartilage, and the upper part of the trachea. With blunt injuries, these are likely to involve the larynx or the trachea. And once the cartilage of the upper airway and larynx are fractured, they don't spring back to their normal position, so they would actually maintain have a continued airway obstruction. And blunt injuries can be collision with the steering wheel, suicide by hanging, or clothesline injury while riding a bicycle. So blunt injuries can cause loss of voice, difficulty swallowing, also an airway obstruction, leakage of air from the soft tissues of the neck, or subcutaneous emphysema. So this is a crackling sensation produced by air. So if there's a trauma to the trachea where air leaks into the tissue, that would cause subcutaneous emphysema. And this can also be a complete airway obstruction. And the paramedics may need to do a surgical airway on this patient. So penetrating injuries can cause profuse and life-threatening bleeding, and we've seen that. You can exsanguinate or bleed out very quickly. And direct pressure is the initial treatment. So we cannot apply a tourniquet. We're also concerned about an air embolism going through the wound and causing a stroke. So we would want to control the bleeding with an occlusive dressing if we can. So larynx, these laryngeal fractures, these can occur when an unrestrained driver strikes the steering wheel, snowmobiler rides into a clothesline, and the larynx actually gets crushed against the cervical spine. So penetrating or impaled objects in the larynx, again, should not be removed unless they interfere with CPR, and frankly at that point it probably doesn't matter. But we want to stabilize all impaled objects if they can, as long as we can get to the airway and as long as we can perform CPR. So a patient with a laryngeal injury or blunt force trauma to the neck, if they complain of shortness of breath, they have a hoarse voice, they have difficulty swallowing, if there's sputum in the wound, then we're really concerned that they're at risk for a total airway collapse. And you really want to get them to the hospital as quickly as possible. And that is the overview of face and neck trauma.